I've had the privilege of being at Children's Hospital the last 5 years. I'm really a clinical child neurologist. I've really been in practice some 30 years. I had finished my training at Columbia and spent a good deal of my time in New York. But I've managed countless young people with all the gradients of head trauma from, fortunately, majority are milder, but also fatal head trauma. So I feel I've got a pretty good sense of the universe of this particular condition. And I recognize one of the mantras today is, the importance of rest and both cognitive and physical rest as part of the healing process. But it does behoove us, I think, as physicians to see if we can do something more for our patients. And so I've always had a keen interest in the background neuroscience and cell biology that's been revealing more and more secrets about head trauma, because there are many questions for which we don't have answers for. And there's a fantasy that maybe that I have, and I'm sure many of us have, that if we could do something that might help prevent the progressive damage of head trauma to these individuals and the suffering, we'd love to discover what that may be. It's a very complicated system, and it's just now beginning to reveal some of its secrets. And I'm going to spend some of my time with going over some of the basic science which has been recently introduced, which may give us some better concepts about the neuropathogenesis of this whole thing. In any case, as I say, recognize we have a common cluster of symptoms, but relatively little in the way of identifiable lesions, although in terms of the imaging, although Dr. Grant is going to show some very new novel techniques which may give us a better way of identifying. And we take care of a lot of young people who have long-lasting symptoms of headaches or school failure or mood problems, and many of them do have pre-existing conditions, so they have double jeopardy. They have the head injury superimposed on pre-existing problems, and sometimes sadly, just life circumstances, and they have a concussion, and I call it the camel's back syndrome, where we have these youngsters who are chronically dysfunctional for months and months at a time, and it's a sad situation. They need, obviously, multidisciplinary help. Medication treatments, Dr. Hawash is going to discuss that at greater length, but a question that comes up pragmatically, if we have this high school athlete who's a promising hockey or football player in a collision sport who's already had 2 concussions, what is the risk of this young person who's going to probably have a lot of upcoming trauma, non-concussive perhaps, in terms of the possibility of risking CTE, the chronic traumatic encephalopathy, in the future? How can we identify such an individual? We have no way of knowing this right now. There are undoubtedly genetic factors, but we don't have any way of determining that as of yet. Anyway, the work I was talking about, which is exciting to me, it's all been in the last year or so, and it's really been created by a bioengineer here at Harvard University, Dr. Kevin Kit Parker, interesting man who actually is he's a veteran, and he was in Afghanistan. And of course, you can't be in the Iraqi or Afghanistan theater without also recognizing that so many of your fellow soldiers have been the victims of blast injury. He was actually a cardiac researcher, basically a bioengineer, and he shifted his focus to nervous system injuries. And what he's really been emphasizing, and as are many individuals in literature, the importance of cell biology in this particular part of the cell called integrin. Integrin is a very interesting transmembrane protein. It basically links the extracellular space and the intracellular cytoskeleton. It's really it's like the Velcro, which holds the nerve cells or muscle cells or astrocytes all within the extracellular space. And it is very subject to, it's not just there passively, it's a very active dynamic system. And messages are being sent from the cell to the outside, and also from the outside inside to the inside. This is a very important part of cell biology for embryogenesis, making sure that the right cells end up in the right spot. Cancer researchers are very interested in this in terms of metastasis and understanding that as a component of it. It's important in platelet function, because when platelets bump into collagen fibers, they send signals to their neighbors to congregate and aggregate to form a clot. integrins are really a very important biological aspect, and they really date back to when we first went from unicellular to multicellular creatures, because that's really the antenna of the outside extracellular space. In any case, what Dr. Parker's been working on and his group are the importance of these particular integrins in terms of neuronal injury and also vascular injury. And when one has these traumatic stimulation, these particular transmembranes send a cascade, a molecular cascade within the cell. And within the cell, they actually cause disassembly of the cytoskeleton and potential further damage. It's as if the outside world is saying, you know, the sky is falling, there's an earthquake out there, we better, and so this cascade that is sent within the cell is to basically retreat and retract. We're finding a lot in biology in general that, and neuroscience, that sometimes the body, in response to some stimulus or stress, has a response which may be maladaptive, or if you will, that the response itself may actually tend to worsen the initial damage. And we see this, for example, in meningitis, where we have an individual whose bacteria has been cleared, but the inflammatory effects on the eighth nerve in the base of the brain may cause deafness. This is a situation where body's immune response has gone awry and has hurt an individual for that reason. This is the cartoon of the integrin. This is the inside of the cell membrane, outside where the greatest bulk of it is, and they say it's like a Velcro attachment, but sensitive antennae. Again, it's one of the cell adhesion molecules, and I've already mentioned this. This is just a cartoon of the nerve cell, but and I just want to highlight the long axon and the cell body, the dendrites up here. Axons are large and they're they're long, and compared to the cell body, this cartoon doesn't quite demonstrate. They're really a good portion of the nerve cell is really the transport to the axon, and axonal transport is very important for the integrity of the nerve cell. And if you could look within the axon, you'd see these cytoarchitectural pieces which are called microtubules, and they transport vesicles, neurotransmitter, they transport mitochondria. They're very important in terms of the integrity of the nerve cell. And again, the microtubules I mentioned within, one of the concerns is that when you have mechanical stimulation, as Dr. Parker's lab was trying to demonstrate, to these integrins, and this is, by the way, not necessarily causing a membrane axon perforation. You're not causing that degree of damage. You're just stimulating the hairs, if you will, outside, and yet it sends this cascade which actually begins to disentangle the microtubule and retract the growth cone of the axon. And the microtubule itself is sort of pictured here, and this blue substance is tau protein, something you've heard a lot about already today. The tau protein in the microtubule, its main purpose is to keep it flexible. And when you lose tau, it gets very stiff. But what happens in this situation, you lose tau. And the concern about tau is because this is something which potentially may have some relationship to the later development of CTE. Tau is a protein which may resemble certain what are called prions, which are agents by which just their close proximity to their neighboring protein, it can be a normal protein, and it's almost like as if these things corrupt the protein into an abnormal configuration, which cause clumping, and this clumping ultimately can lead to nerve cell death and damage, and this can happen potentially years down the line. So his cell culture model was basically to take neuronal rat cells in a petri dish, but on an elastomer base, so he could determine the effects of different kinds of stretching or trying to simulate a blast wave or a concussion type. And what's particularly exciting about his research is that, recognizing this cascade of events is that maybe indeed there are some issues here which might lead to potential future treatments. And indeed, pharmacologic inhibition of the integrin-induced Rho kinase, that's one of the molecular cascades that sends this microtubule into disintegration, may actually help reduce the axonal injury. So if you could treat potentially soon enough, you might prevent this kind of problem. And this is just a cartoon of his high stretch model with the neuronal culture. And this is what it looks like. And from my perspective, when I see that, that's my sort of image of what a concussion may be in that regard. It's nothing on one surface. It's a multi-level, it's multi-planar, and that kind of jostling. This actually, he uses both this model where he does this stretching. He does another model to simulate the injury of a blast or a concussion by taking these magnetic beads, which you picture it's up here, and basically tugs at one of the dendritic areas. This is the axon, by the way. And by virtue of doing this, by just it's like a rubber band you pull out and release it. But what you're going to see in this little image is that this axon looks there's a pretty good continuity, and what you're going to see is some retraction of the axon and some blebbing of it. And this is actually on the other side of the cell soma. So this is, if you will, a global injury which is caused by a local problem. The idea is that they're all in communication by this biochemical cascade. Oh, sorry. That's wrong last time. I hope you can see that. So the concept here is that even minutes afterwards, you see this histologic change in the axon as a result of that pulling. In any case, it also turns out to be that in addition to the axon, that actually Dr. Parker's group has looked also at the vascular smooth muscle cells, and this is very important in terms of vascular regulation within the nervous system, and in fact has used a similar model looking at these cell cultures, and has found also that, again, traumatic stimulation of the integrin, which is also a component of the vascular smooth muscle, can also result in a cascade which causes vascular spasm. We talked about the importance of vascular spasm in terms of further potentiating injury. The nervous system is trying to heal, and meanwhile, the blood vessels are providing less vascular supply. It's double or triple jeopardy. And again, what he found with some of these experimental chemicals is that the Rho-ROCK inhibition within the vascular smooth muscle can actually help prevent some of this vascular spasm, and that's important. Now, vascular spasm has been known to occur in subarachnoid hemorrhage. We certainly see that in head trauma as well. But I'm talking about the much milder head trauma, the one that doesn't result in actual bleeding, but just the jostling and the typical concussion. But there still is vasospasm, and that sets up that discrepancy which has been discussed today. Now, this is just sort of a summary slide of what I've been saying in terms of the biochemical cascade and the importance of this kind of research. This is actually within the. I wanted you to focus here and the different strains by which the cell culture was affected, and if you will, the ROCK inhibitor, when given immediately after the stretch, had clearly significant benefit in terms of diminishing the focal swelling of the axons. And again, we get back to this particular concern in terms of the ability of the body to handle this, the disintegration of the microtubule and this repair mechanism, which obviously is very important, that takes place normally in terms of a post-head injury. And again, the danger potentially, or the potential for problems to ensue because of this, the freeing up of this tau protein. There are a number of so-called Rho-ROCK inhibitors which have been already identified, and they've not been used for head trauma per se. That's hopefully going to come, but there have been other ones, and it's interesting. That's an interesting list of medications. You'll recognize this one of the statins people use for heart disease. Interestingly, people recognize that the statins may help for people with heart disease, not just by lowering cholesterol, but other so-called pleiotropic effects, which may in fact involve these integrins. Fasudil is something which is a calcium channel blocker, typically in subarachnoid hemorrhage. There are all sorts of vasospasm, and that's actually been useful here, but it's not been introduced. It's not been approved in our country. It's only used in Japan, but they've seen some pretty good success with it in different kinds of neuronal stress, including in ischemic stroke. This is a medication apotholone D, which basically helps to stabilize those microtubules. It polymerizes and makes them more flexible. So this may be also very important. And finally, while not necessarily an effect on integrin, propranolol, which has been used in other circumstances and talked about, we'll talk about it more, may be helpful in the early stages in terms of lessening this vasospasm that occurs. There's often a tremendous outpouring of norepinephrine and adrenergic stimuli, so that may be helpful also in terms of the nervous system recovering itself. So this is kind of an exciting time from my perspective. I'm a clinician and I'm looking at I'm not a basic scientist by any means, but I see this as an opportunity to really get a better understanding of the neuropathogenesis of head injury, and maybe, just maybe, that we could determine some kind of therapy rather than our therapies now, which are really kind of ex post facto, trying to help with the neuronal or software dysfunction that has already occurred. So with that, I'm going to turn the microphone back to Bill and to Karameh. So thank you.
Great. Thanks so much. So that was a look at the molecular pathophysiology and some medicines that may be coming down the road that are worth researching. Dr. Karameh Hawash is a neurologist at Children's Hospital Boston. She is a specialist in headache management and in concussive brain injury, and she's going to talk about uses of currently available medications in the management of chronic concussive brain injury.
Thank you, Bill. Okay. So, as you all heard, the symptoms of post-concussive headaches are quite variable and they overlap. However, the headaches are the most common symptoms that occur after concussion. They do not always correlate with how severe the injury is. Some patients present with what seems to be a trivial injury, but they continue to have prolonged headaches after the injury. Others present with what seems to be severe injury, and they stop having symptoms within days. We do not understand this phenomena very well. It might have to do with the rotational forces theory and other things, but I'm just going to focus on how we treat the post-concussive symptoms, including headaches. And when we talk about headaches that occur after a concussion, practically speaking, the headaches can be divided into acute, meaning they occur immediately after the concussion. They last for a couple of weeks, and then hopefully they resolve spontaneously. But in 15% or 20% of cases, the headaches continue to persist, and they can last for longer than 4 weeks. And that's when we start thinking about ways to treat these headaches. So when I think about methods or a method to treat my patients with headaches, I try to think of something that will be rapidly effective, that does not have side effects, and that seems to be tailored to the characteristics of the patients and to the comorbidities with the headaches. So there are two ways of pharmacologically treating post-concussive headaches or post-traumatic headaches. Acute treatment, which is treating with over-the-counter medications like triptans or nausea medication. With these medications, we can use them. At the same time, we have to be cautious because of the potential of rebound headaches. If a patient uses the medication for more than 15 days per month, the potential for having rebound headache becomes great. And it's important to caution the patients when they start having headaches to avoid using over-the-counter medications as much as possible so that they do not end up with the rebound headaches. In terms of chronic treatment or preventative treatment, there are several families that one can choose from. The main ones are anti-seizure medications, which can be a little bit anxiety-provoking for patients and families when you tell them, I'm going to treat you with a seizure medication. But what I often say is that seizure medications have been tried in migraine headaches extensively. We use very moderate doses that are quite small, and we try to monitor the side effects very carefully. And that seems to be helpful in relieving anxiety about the name of the medicine. Antidepressants, same thing, or antihypertensive. Antihistamine seems to be the most, the nicest. And in the Brain Injury Center, we try to follow algorithms so our management can be consistent and standardized, and so we can understand whether our treatment is working better. So when we think about the symptoms, we try to divide them into several groups. As you all know, headaches are the most common symptoms, but sometimes patients present with vestibular symptoms, trouble with balance, or lightheadedness, or trouble with hearing. So with this group of patients, we often refer them to the balance program and recommend vestibular therapy. For another very important subset of patients are the patients who present with cognitive symptoms. Cognitive symptoms can even aggravate the headaches if they become frequent or severe. Patients feel good, they go to school, they start doing homework. Instead of continuing to feel better, they start having more headaches. With these patients, sometimes we consider treating them with stimulants or treating them with medications like amantadine, depending on the situations. As I said, this is a smaller percentage of patients that we have to use these methods with. Some children, especially younger ones, present with emotional symptoms, irritability, trouble with transition, being not agreeable. The symptoms can be quite severe to the degree that it affects their lifestyle and it affects the quality of their life, and we can consider treating them with medications like clonidine or guanfacine if needed. And I will move on to the headaches algorithm that we created, keeping in mind the age of the patient and the comorbidities with the headaches. So in patients who, and obviously we treat when the symptoms are frequent, and more than twice a week or 3 times a week is considered frequent enough to consider pharmacological treatment. And we try to divide them by age, so patients who are less than 10, the safest option would be to try something like cyproheptadine, which is an antihistamine. Patients above 10, we try to look at them as a whole and figure out what comorbid symptoms do they have. And as a start, if there are patients who present with anxiety, we can consider propranolol as a treatment, which has been shown, as Dr. Wolff pointed out, to have some protective role in traumatic brain injury. However, that has not been proven in chronic treatment. So propranolol could be a consideration. If they have history of excessive sleepiness, which is a common symptom, then we try to understand, do they have, if they have excessive sleepiness, we try not to use amitriptyline or any medication that can make their sleepiness worse. And we go to the yes group. If they are very sleepy, we ask them if they have family history of migraine or if they have a personal history of migraine. If the answer is yes, we try to understand whether they have a learning disability to make a determination between nortriptyline and topiramate. Topiramate is a medication that has been shown, especially in seizure doses, to cause some cognitive dysfunction or memory or word-finding difficulties. We try to avoid using that if a patient is already presenting with cognitive symptoms. And nortriptyline can be a very safe choice for these patients. If there is no family history of learning disability, no excessive, and there is no sleep difficulties, gabapentin can be a consideration as well. and I'll go back to amitriptyline, which is a very commonly used medication. It has been studied more often than other medications in the population that we treat. Amitriptyline is a very safe medication. It can be used in a small dose. A lot of the kids have trouble falling asleep, so when we use amitriptyline, we can treat the trouble falling asleep with the amitriptyline, and that seems to make the management of the headaches faster and easier. And sometimes when there is trouble falling asleep, we can use melatonin, which is over-the-counter medication at times. So this is basically a sort of a map that can guide us in making decisions. It's not what happens all the time, but it's something that one can look at and try to understand which direction to go. Before I finish, I'm just going to talk about alternative treatment for post-traumatic symptoms, including headaches. We often recommend acupuncture, which has been proven to work very well for post-concussive symptoms. Sometimes neurofeedback is considered. Sometimes a visit to the chiropractor once a week can be very helpful, especially if there is neck pain. Supplements have been studied and have been found to be effective, like magnesium or butterbar or other things like that. And the alternative option is always an attractive option because we can avoid side effects from medication. We can avoid frequent over medicalizing the post-concussive syndrome. I think that's it. Yeah.
Thanks so much. So most of you who care for concussion know that we're somewhat limited in what we can do, right? Patients report their symptoms. Their signs often go away. Maybe you're lucky enough to have computerized neurocognitive testing, but wouldn't it be great if we could see it, if we could picture it, just like we do a fracture, just like we do subdural, and we are limited. CT and MRI, the way they are now, don't show it to us. We're fortunate enough to have Dr. Ellen Grant here to talk to us about what's coming down the road in neuroimaging. She works at Children's Hospital Boston, and her specialty is brain imaging, and she's going to talk about the cutting edge type of techniques for imaging that are coming down the road. Ellen?
Thanks, Phil. Thanks, everybody, for staying awake so long. So I'm just going to start off with what we do routinely and what is the role of imaging right now. Typically now we get imaging if there's a history or physical exam that's concerning persistent symptoms, severe headache, unexpected length of loss of consciousness, or the character of the impact. And that's primarily to screen for associated injury, not for, at this point in time, we're mostly screening for secondary findings, not for the concussion itself. And what we're looking for is with CT, we do CT if it's an acute, because you can get it immediately to look for fractures and for blood products, especially if that's going to change patient management. And MRI, mostly structural imaging, to look for hemorrhage or diffuse axonal injury, which is not there in the vast majority of the cases. So the vast majority of the time, the routine approach, as I show here, is completely normal. Just an example of some of the secondary findings that we're screening for are things such as this, a big epidural hematoma with areas of acute bleeding that would be a surgical emergency. So if there's symptoms that are severe, we screen with CT. At Children's, we use low-dose approach, and most of the major hospitals here have switched from CT to low-dose approaches so that we can still see hemorrhage well, but we're losing our sensitivity for subtle foci of hemorrhage in that trade-off. So our ability to use CT to look for parenchymal changes is decreasing as we minimize the radiation exposure because of the concerns for long-term cognitive effect from that radiation exposure. So if we're looking for subtle abnormalities in symptoms that persist, for example, we may go to MRI to look for subtle hemorrhage. And here's an example of what we typically, or we can find in some cases, is these little punctate foci of low signal that only show up on MRI, particularly some of the newer sequences that really emphasize a hemorrhage called susceptibility weighted imaging, or SWI. And these are routinely available at most centers right now. But the problem is that most of the time the imaging is normal, yet the patient feels abnormal. So why is that? And this is something we struggle with in imaging a lot of the time, and where we've moved to more sophisticated quantitative imaging, because the brain imaging is structurally normal in many different neurological disorders, so we're struggling to find better markers. And I think in the case of concussion, the major issue is that the changes are at least initially functional changes. They are not structural changes. So you can have physiological effects that will not be visualized by just looking at the cortex and gray-white contrast, for example. What we need is advanced imaging and using these new physiological methods that can hopefully help us detect subtle functional changes and come up with biomarkers of when patients should return to play, for example, based on the physiology of their brain. Sort of like it's emerging now in stroke therapy. We look at the brain physiology with diffusion and perfusion and determine treatment based on that, not hours since when the patient was last seen normal. This is a type of approach we want to move to in concussion treatment as well, and therapy guidance. And ideally, basically, is we want to make this biological process visible. So all the stigmata that was discussed earlier today, it starts to disappear because we can show real biomarkers of physiological change. And I think people earlier might have shown this. This is some of the classic data from Giza and Hufta on the rat models in 2001, showing the cascade of physiological events that can occur after concussion. And if you they've shown that there's ionic shifts, which, if you think about imaging translation, we can pick up some of that with diffusion-weighted imaging. If there's compartmental shifts, they may not be enough to visualize, but we can detect quantitatively some subtle shifts. Altered brain metabolism, MR spectroscopy is good for that, and if there's flow correlates, we can pick it up with arterial spin labeling. Impaired neural connectivity, there's lots of structural and functional connectivity measures I'll show you a couple examples of. And disrupted neurotransmission would be possibly picked up with some functional methods as well. And just looking at this graph here, again, if the cerebral blood flow and metabolism are decoupled, that drop in CBF, we can search for that with, again, arterial spin labeling, lactate, and glutamate with current MR spectroscopy methods. And there are emerging techniques that I didn't put in the talk, but we are trying different methods with MRI to give you estimates of whole brain and regional glucose metabolism. So right now there's a number of papers out showing with single voxel spectroscopy in different regions. You can pick up often decreased N-acetylaspartate. It's an enzyme that's within the neurons. It's created in the mitochondria. It can be transiently decreased when there is neuronal dysfunction or decreased mitochondrial function within the neurons. Glutamine and glutamate can be picked up in spectroscopy right now as well too, which are markers again of the excitotoxic cascades that can happen, or suppression in the early cases of concussion. Choline is a marker of membrane turnover that can be increased. Typically, it's been reported elevated more in the later stages, and minoxidil is more specific to inflammatory changes, and that's also been reported to elevate over time. GABA is another neurotransmitter we're starting to look for in spectroscopy at 3T, and there's some newer sequences that are out. Take about 5 to 8 minutes to see it, but those are mostly specific regional measures right now, but we can start to even think about looking for GABA. The newest sequence that we have right now, instead of doing single voxel, which takes about 5 minutes, we get a whole slab of the brain in about 2.5 minutes. So it's about half the time, as similar actually signal to noise for a smaller voxel size, and you get a grid, so I can look at the spectra in any box here over multiple slices. And the problem with MR spectroscopy in the past has been you're so dependent on where that tech or the physician places the spectroscopy voxel that it's hard to compare patient to patient because there's a lot of regional variability. Now that we're moving to these volumetric acquisitions that are a very feasible time scale in terms of putting into routine practice, we can co-register the anatomical scans and then have the spectroscopy compared in similar regions in multiple patients. So it's making quantitative spectroscopy much more accessible without very strict oversight with the spectroscopist at voxel placement. Cerebral perfusion is out there. It's actually FDA approved for GE. We have WIP packages on Siemens and some other prototype sequences that we're testing out. And I think Philips also has a WIP version. These are methods where you label blood as it's flowing in the carotid arteries and the vertebral arteries, so there's no contrast involved. It usually takes about 5 to 7 minutes, and you get regional blood perfusion in milliliters per 100 gram per minute. So it allows us to really assess perfusion quantitatively, unlike when the other methods where you bolus contrast, it's not quantitative. And then you can compare normals to abnormals. And this is just an example of a young child. The one on the right had a skull fracture and otherwise had a perfectly normal MRI. And was dictated normal. I reviewed it, a perfectly normal scan, even with SWI and all the fancy bells and whistles, diffusion normal. But the blood flow was almost 3 times that of a normal age-matched child that didn't have trauma. This also brings another point, is that the response to injury is very different dependent on the age of the subject. In the younger children with the acute trauma, it's much more common to see high blood flow, whereas in the older kids, the decreased blood flow, as was shown in those adult rat experiments, is more common. We're starting to do this as a routine in our patient population. It's on the Siemens, not FDA approved, so sometimes there may be issues with billing for adding this sequence. But I think there's a lot of potential to detect changes early, and if treatments are going to be targeted towards vasospasm responses, for example, as was discussed earlier, then this might be a good sequence to screen for appropriate candidates and monitor for individual response to therapy. And again, a lot of what we're working towards is trying to do individual, not group, treatment analysis. Diffusion tractography is another thing. You can take your diffusion acquisitions, and let me see if I can get the little video moving here. You can take your diffusion acquisitions, and this one here on the right is a whole brain reconstruction of diffusion tractography that actually is a standard clinical acquisition. It's a 5-minute acquisition that almost everybody can acquire at any scanner in the city here right now. And we can construct these tracks that correspond to white matter coherence and large axonal bundles. And using these approaches, studies have shown that there is decreased connectivity, particularly in decreased tracks that you see, particularly in the dorsal frontal regions. And in some cases, you can pick up areas where the tracks appear to be disrupted that may correspond to those axonal retractions that were shown earlier too at a microscopic level. If there's a large enough group of them that show changes in a region, we should be able to start to pick them up. So we can start to pick up these disruptive connections. And also we can use other methods that are just emerging now, and we're trying to make these into pipeline analysis so they will become more available routinely. And as these tools become available, we're posting all the code on the web, so that it's open source code, where you can take your structural MRI, again, which anybody can do pretty much in any scanner, 1.5 or 3T, and you take the structural scans, and then you subdivide the brain into regions based on the individual spiral anatomy. And then you can look for each region here, how many of these, of the diffusion tractography tracks come from one region and go to the next region, and then I can connect or create a map of brain connectivity from one region to all other regions in the brain, and create these matrices where all these ROIs or regions are listed here, and assess connectivity. So this makes it or allows us to take an image such as this and create a quantitative map. So now we can do comparisons between individuals, create group means, and then just like we do with head circumference, start to create graphs of normal versus 2 standard deviations from normal and so on in each of these regions. So we will be using those methods as we're moving forward, I think, to get a handle on those changes in connectivity that can be transient, because those maps can change with time. Also, what's becoming more common is not just looking at functional MRI, where you go in and ask a specific tract, but what's called resting state functional connectivity. And these resting state methods are extremely easy to do. You just get the patient to sit in the scanner and close their eyes and do nothing. And you scan with an echoplanar sequence that every scanner, again, in the city has for about 6 minutes. The analysis code, there's another number of different things on the web that's freeware to do the analysis. We'll have more actually coming out with recommended parameters. But what you can do is then look at what regions of the brain oscillate in synchrony in terms of the blood flow. And those areas are called connected, functionally connected, if they oscillate in synchrony. And you can create maps of which areas fluctuate together. And when you compare patients with concussions to patients, and this is mild concussions with no structural abnormalities visible, there are studies showing now that the interhemispheric connectivity is reduced in many different regions. And there's a number of papers out showing a bunch of different networks, from memory networks to other networks, are disrupted. This type of approach has been used in ADHD in multiple sites to actually now start to differentiate different subtypes, and to even age the age of a child, or determine the age of the child based on the network. So this is a very promising method moving forward. We just need to get the standard deviations, so we start to map each individual compared to normal means. Similarly, for structural imaging, right now there's a little some data out there indicating that with mild traumatic brain injury, whole brain volumes can be decreased, and there can be focal white matter loss as well that can be detected. However, using more sophisticated methods, such as, say, the free surfer's segmentation approach, you get about 40 regions, I think, that you can analyze. And for each of those, we can build up means for population means. So we're going beyond the head circumference to every little region that we can segment, having a standard curve, a growth curve. And we've got grants submitted to do this with archives of data that we have within children. So hopefully we can gather the data and make public the normative curves, so individual sites can do such analysis and plot them against normal. It does take a while to run this software. It runs at about 24 hours right now, but we're partnering with computer software companies, IBM, and researchers to try to speed up these so they become rapid turnarounds, ideally within an hour, so that as a patient comes off the scanner and the reports are dictated out, that data is there to add to the report. So moving forward, I think we'll have a lot of methods to make concussion clearly identifiable as a biological disorder, to come up with methods to make it clearly visible using MRS, arterial spin labeling, tractography, resting state, and also structural analysis moving forward. Thank you.
Thanks, Ellen. So, you know, I was going to talk about a general approach to managing concussion patients, and I still can do that, but there's only about 10 minutes left. And so I don't want people walking out of here with questions of things. So I would say maybe even before we start, and if it's just a part of my talk, I'll just do the talk, but are there things that people want me to discuss or want to have answered before we begin? Questions that we can answer. Yes?
For Dr. Hawash, why do antihistamines work for children with post-concussive headaches, and will it also work for adolescents?
The mechanism is not very clear. The theory is that all these medications that prevent headaches stabilize the cell membrane in some capacity. The exact mechanism for cyproheptadine or any antihistamine is not clear as far as I know. Bill can correct me if I'm wrong.
Actually, it has a calcium channel blocker going, which may be the reason. I'm sure that it has many different pharmacologic effects. But that is touted as one.
I would say you have to understand the pathophysiology of a post-concussive headache to know what the mechanism of the drug is. And since we really don't know what the pathophysiology is, it's all guesswork at this point.
So to answer your other part, could it be used for teenagers or adult? I have used it a lot of the times. When there is a contraindication for amitriptyline, for example, if there is a cardiac condition, or if there is, the other medications do not seem to fit for that particular individual, I use Periactin quite often. Yeah.
Thank you.
You're welcome.
Yes, sir.
PET scans, because of the radiation exposure, are hard to do on a research basis, and that's why there's very little in the literature. And it's hard to actually do any research protocols to see if they're useful because of that barrier. So that's why, again, it's more used in the adult population because it's a lot easier to get an IRB through with radiation exposure in adults than kids.
Yes.
This is sort of a general question, not specific to what we're talking about here, but are there protective factors for some kids that either help them, I don't know how we can figure this out, help them not get concussions, or
Yeah, so the question is there a way to prevent concussion, basically, or protect them, or yeah, set them up? Yeah. Yeah, so on the basis of the individual as opposed to changing the rules or changing the equipment. There's two things that you can do that are not sexy or technological, but they work. The first one is particularly in collision sports like football, men's ice hockey. Most concussions occur when the athlete doesn't see the hit coming. If you're playing this sport forever, you know how to absorb a hit. But you can only absorb it if you see it coming. And Jason Mihalik actually was the first to take this from a theoretical idea and put it into practice. And it turns out that in ice hockey for boys, if they see the hit coming, they're less likely to get a concussion. So many of the coaches are now saying, play with your head on a swivel. Basically, they're just saying, be aware of what's going on around you. For ice hockey, particularly going into the corners. The second thing, which again, not sexy, but works, if concussion is due to a rapid rotational acceleration of the head after impact. And Dr. Cantu put up the formula, force equals mass times acceleration, okay? So the human head, the whole thing probably weighs about, I don't know, 8 pounds, 7 pounds, 6 pounds, right? If you hit it with a certain force, you'll spin it, you accelerate it. If you instinctively have flexed your neck muscles, the effective weight of the brain goes from being 6 to 8 pounds to, in my case, 210 pounds, because it all operates as one unit. And even when you don't see it coming, there's a certain amount of tonicity in a muscle. It's never totally relaxed. And it turns out the stronger an individual, the higher rate of tonicity even at rest. And so by strengthening the neck muscles, again, you can decrease the risk of concussive brain injury. So there's 3 ways to do it. There's what's called a one-way machine or a 3-way machine, which we use for Boston College and Northeastern, these complex. But you could do this with an athlete very simply. The head doesn't move anywhere. They do isocentric contractions, okay, isotonic contractions. You put the head here, and you have the athlete push as hard as they can against the athletic trainer or physical therapist or coach or parent's hand for 10 seconds. You do 5 reps of repeat. The head doesn't go anywhere. They're just putting all their effort into it. And you can do it in all directions, forward, backward, side, side, and then the 2 rotational directions. Yes?
So it's not the traditional like weightlifting we think of, like doing laps and traps and stuff like that. It's isometrics and things like that.
It's isometrics really to get the neck muscles. Now, I actually do recommend lat pulls and military press and even regular press and shrugs, because I think you get the posterior shoulder muscles going to be helpful too. But for the neck muscles, it's easier to do the iso. That's exactly right, yes. Absolutely. Females have decreased cervical muscle bulk and strength, and so probably more important for females even than males. There was somebody else over here. Yes?
So you would recommend those exercises for all athletes in their training?
I would, absolutely. And actually, the stronger the muscle bulk, it lowers your risk of cervical spinal fracture as well, because the more force the muscles absorb, the less go through the vertebra. So, yes? You could do them. It's just so much easier to do the isometric. In fact, if you have a one-way machine or a 3-way machine, they will do all forms of muscle strengthening. But if you don't, if your resources are limited, it's easier and safer, I think, to do the isometric.
Is that like the old school one you're talking about, where you flex the neck against the weight?
Yeah, we have one actually. At the,
Gone away from that. So,
yeah.
you're kind of scared to go back to that.
That's right. We use it for research purposes mostly because it'll measure your range of motion as well as your strength. Yeah. Great. So, it is, in fact, almost 4:15. I'm happy to stay and talk, and I was going to do about 15 minutes of my general approach to concussion. I will not be insulted if you leave. I realize we'll probably go a couple minutes over time, but if you want to hear the way I do it, the way we do it in the Sports Concussion Clinic, I will tell you. I just want to make sure you all got your questions answered. So, for those of you who are here this morning, you know that the mainstay of management, once you have diagnosed the concussion, is rest, physical rest, cognitive rest. I think that's been beaten to death, so I'm not going to go over it. I just will say that I think it's helpful to illustrate to the athletes that the brain needs glucose to recover, and that if you do something else that demands glucose and pulls it away from the brain, it's going to impede your recovery. I think otherwise they think rest is nonsense, okay? So I think some sort of explanation of the physiology of it is helpful for most athletes. Physical rest is intuitive to them. That's what happens when they sprain an ankle or tear their MCL. But cognitive rest is a newer concept. They don't get it. And so, again, I just go through and explain it to them. If you do physical rest, cognitive rest, and then this graded return to activity once they are symptom-free at rest, That really is the medical management of concussion. 97 to 98% of athletes that sustain a concussion in high school sports will be fully recovered by the end of a month. And so for most of the athletes you're going to manage, that's all you need to do. Rule out other injury, make the diagnosis, put them at rest, and when it's time to go back, put them through a graded protocol, a return to play. And if you say, look, I don't want to be a concussion expert, I don't want to see a lot of this, I just want to be able to take care of the kids at my school or on my team or in my office, that's all you need. And you're going to get most of the kids. So I would say everybody who attended this conference should do this, should see concussion patients and do the initial stages, piece of cake, okay? Yes? What about the computerized testing? So there are other assessments, yes. So there are other assessments you could do, and I would say there's 3. So if you want to measure symptoms, obviously, if you just ask an athlete, are you feeling better? They will always say yes, because they always want to play, and better to an athlete means well enough to play. It doesn't mean, am I completely back to the way I was before my injury? So secondly, we talked a little bit about the balance error score this morning. You can measure an athlete's balance, and the way to do it is if you're going to take care of a lot of these athletes, you do it before they ever set foot on the field or on the ice or whatever, the court, wherever they're playing. And if they get a concussion or you suspect they have one, you remeasure it and you compare their balance to their preseason baseline. And you can use any changes in their balance to watch them improve and monitor their recovery. And then lastly, what this gentleman is getting at is you can measure their cognitive function. The easiest way to do this, the most reliable way, is on a computer. You have to buy a program. There's several of them. Dr. Taylor showed the ones that are available this morning. It takes about 25 or 30 minutes, but it will measure their function. And I showed you the reasons why I think it's important. So this is the symptom scale. Again, I think you saw this morning. It outlines the most common symptoms of concussion. Ask the athlete to rate them. This is the way it was validated, okay? To be honest, in my clinic, I put instructions at the top. It says, I only want to know about the symptoms that were started at the time of your injury and you've still been experiencing in the last 24 hours, right? Because if you just give them the symptom scale, kids that chronically have headaches or trouble with sleeping or something will circle all that. And if you didn't have a baseline symptom scale, what do you do with that? Furthermore, some kids will be symptom-free with full cognitive exertion. They made up all their schoolwork. They're symptom-free with full physical exertion, but the night before they came to see me, they were up with a cough, or their girlfriend dumped them, or they failed a test. And so they circle, I'm sad, I couldn't sleep last night, I got low energy. I don't want to know about that. So I specify the instructions. We do that, we submit things for publication, and people say, well, it wasn't validated that way. But, I mentioned it to the guy who developed the scale. He said, geez, I wish I thought there was a better way to do it. So, you have to be practical with these things. People get caught up, I think, in the specifics. I'm not going to go over does somebody want me to go over the balance error score? You can see it online. I went through it briefly this morning. Yeah, I don't think so. So really, this is neurocognitive testing. Now, this is tough, right? So if you are in private practice, you have to pay to get this. There's a couple ways to do it. For us, who do 3,000 of these tests a year, we pay for the online version. I think it's about $7,000 to $10,000 a year. You get 500 tests for free, then you got to pay for each test after that. So it might not be practical if you're not doing a lot of these. But at least a few years ago, you had the option of buying the software for $300. Now that would be practical. You don't have to pay for a test then. You own the software and you just do it as many times as you want. So I would say to do that. If you're at a school, if you're an athletic trainer, get it. And actually, for athletic trainers for schools, you could probably get the online version because they do these special deals where you can get that for $300. Compared to helmets and shoulder pads and ice maintenance and field maintenance, another $300 is trivial. It's true. If you have enough money to have a football program or an ice hockey program or even a soccer program, you have enough for $300 to buy the software. If you are a pediatrician or an internist, family practitioner, somebody, neurologist does this in clinic, it can be tougher. It takes up an exam room for 25, 30 minutes. Depending on where you are, you may or may not get reimbursed for this. In Massachusetts, it depends. Some insurances do, some don't. And of course, it ties up an exam room. So I realize for me, this is easy. I got all the resources in the world. I don't even think about this stuff, to be honest. But it would be harder in private practice. I will say, if you invest in it, you have to learn how to interpret it. You have to learn to determine what is a valid test, right? A lot of kids will try to dog the baseline. You heard Dan LeCouture say that today. You can detect that. There's paradigms put in it so that you could tell if somebody's purposely throwing the test. But if you never learned on it, you never trained on it, you're going to miss that. And lastly, if you offer this, you will increase the amount of patients you see. People are dying to get their concussions managed properly. And so I would say the financial benefits you would get from the patients you gain to your clinic would outweigh the costs of not getting reimbursed for the test itself. And of course, it really is the best clinical practice, and so you would be providing that to your patients. We offer baselines for like $20 or $30, so you don't have to pay for a visit, you don't have to pay for a doctor, you just pay cash and you get the test done. We sort of do it as a service for people that don't go to a school that offers it. I think that's a good thing to do. I understand that financially it's not, you probably lose money that way, but we'll often even go to schools. They got a computer lab with 100 computers. I'll go do 100 kids at once just for free, you know, just to do it. I think you could do it to build your practice if you're worried about the finances. So I would say if you see someone in the office, you rule out other injuries, concussion not the only neurological injury in sports, but the most common. You put them at rest, and then when it's time to go back, you put them through the return to play stages, and that's all you're going to need. Now, if their symptoms go on for a long time, we tend to break it into categories like Dr. Hawash said, and then we do medical and non-medical management based on where the predominance of their symptoms lie. So headaches, we do this. Cognitive symptoms, we do this, etc. She went through that. I'm happy to answer questions if people have it, but my general approach is initially, I just rule out other injuries. I just put them at rest. When we get to 3 or 4 weeks out from injury, if they're totally better, great. Then I start returning them to school, returning them to sports. If they are not totally better, but they're a whole lot better, okay, I just wait a little longer. I still don't do anything else, right? I mean, there's no need to do all this new fancy techniques and medicines and everything if they're getting better on their own. And so really, this is really applicable to the kids who are now 3 or 4 weeks out and they are not substantially better. And then I consider imaging, because if 98% are better within a month, and it's been 4 or 5 weeks, I got to wonder, is this in fact concussion or is it something else? Most of the time the imaging's normal, but if they have a subdural that's not going away, you're never going to know, right? They just linger. They don't get better. So I image around that time if they're not improving steadily with conservative management. And then I consider medication based on the things that Dr. Hawash thought. So I don't even consider it until we get to this 3 or 4 week mark. And then lastly, it comes up, well, when should someone stop playing collision sports or even contact sports? And people always say, is there a number of concussions, which is a reasonable thought. But it's not just the number. I think of a whole lot of things. Number one, if it seems that they are getting concussions with less and less force, the first couple they got, bam, were major blows to the head, and then they just get bump off some guy's shoulder and they get symptoms or cognitive dysfunction or something, then we start thinking about it. Yeah, maybe we should retire this athlete from collision or contact sports. If it's taking them longer to recover, they got better the first few days for the first few concussions, then a couple of weeks, now it's taking them 8 months, I start to think maybe it's time to back off. If their symptoms are worse, they're more severe after injury, or if their cognitive dysfunction is getting more and more pronounced with each injury, we think about retiring from these sports. And then lastly, the overall number. So my typical approach, if everything else is reassuring and it's really just the number, they've had several, at their third concussion, I bring it up. I say, by the way, there is some cumulative effect on the brain that doesn't go away, and you have to understand the risk. And I go through the studies in normal person terms, but I go through, here's how we know this. And most athletes at that point say, I got you, I hear you, I understand the risk, I'd like to go back. I think that's totally reasonable. I sign the form, I send them back. At 4, 5, somewhere in there, they have to make a tough decision. And I make them go home and talk with their parents and their doctor and their coaches and athletic trainers and people who they're friendly with that played their sport. And they have to decide how important is it to them. If they say, you know, I got 5 concussions, but I play ice hockey at Boston College and I'm signed with the San Jose Sharks and I'm going to make $1 million next year and I'm supporting my family that way and therefore I want to take the risk, hey, I think that's totally reasonable, right? I wouldn't wash windows up on the 20th floor, but some guy does it, he takes a risk, that's reasonable. It's how he earns his living. If they play for, you know, Brookline High and they're really number 1 on the tennis ladder and they're like riding the pine on the bench and they get hurt every year and they don't really like ice hockey, then I say, well, now's the time to quit. This is not worth it. So, it's not always that simple. There's in-betweens there. It's real important to some guys who aren't good. I understand that. Again, it's really their decision. And for some guys, they're small. I love ice hockey, but I'm 14 and I'm like 90 pounds. And the guys on the ice who are 15, because we play 14, 15, are 6'2", 180 pounds. I'm getting creamed, right? And for those guys, sometimes we'll say, look, take a year off. Lift weights. Work on your skills. Get great at skating. Hit your growth spurt. Come back next year, be 40 pounds heavier and a lot taller and stronger and faster and more agile, and go back. That would be safer than just keep going back. And so I think all things are on the table. Listen to what's important to the patient and explain all your options. The only unique thing about concussion is you have to sign something before they go back, right? Smoking causes death. Everybody knows that, right? You tell your patient not to smoke, they go out, they smoke. Right? But it's got nothing to do with you, right? You told them it's bad for your health, there's a risk. But for concussion, you have to sign a form that says, I'm allowing them to go back. That's the real difference. So I sign it, yeah, but I'd leave it up to them. I mean, for the most part. Now, of course, there are athletes who want to go back. And most of the time, if I really feel like they should retire, they do. But there's been 3 or 4 who I couldn't sleep at night if I signed their form to go back. And I remember one young lady in particular, I just said, look, I was practically crying in the office. I just can't do it. I can't do it. So I offered her a second opinion. You always find some guy who'll sign it. I mean, it's not an issue. And they did. Man, patients don't care. They know it's hard for you. So I just tell them, I can't in good conscience sign your form. That's rare. So I guess I said this without going to the slide. So I'll take further questions. That's really all I had to say. Yes, sir. Yeah. Yeah. Yeah, that's a great question. So you say, what if there's only one concussion, but it was wicked bad, right? Maybe it took them 8 months to get better, and they had severe symptoms, and et cetera. Does that influence when you put them back? It does. So for me, the longer it takes you to recover, the longer your symptom-free waiting period before I put you back, if I put you back. With one, for most athletes, I will say to them, listen, if you decide these sports are important to you and you want to go back, I'm with you. I will sign your form and let you go back. But do you really want to go through this again, And I do the same thing. If it was a long recovery or severe symptoms, even if it's their first, I say, go home. I don't want you to tell me today. Talk with your parents. Talk with your pediatrician or your internist. Talk with your wife or your mother, your coach, all of it, and decide how important is it to you. And they come back, and then they have to explain to me why they want to, if they want to. And then I build in an extra symptom-free waiting period. Now, for the really young kids, I would say less than 12 or 13 or so, I like a day symptom-free for every day they had symptoms before I let them do contact, to a point. Right? If it takes them 3 weeks before they're symptom-free, I want 3 weeks without symptoms before they do contact for the young kids. If it takes them 3 months, I like a month symptom-free. I don't make them wait 3 months, but I like a full month then. For the older kids, I'm a little bit more aggressive. So, if you're 14 to 17 or something and it takes you 3 weeks, I'd like to get 2 weeks in, For Northeastern, they get when they're better, they start the stages. I mean, that's the reality. Their whole livelihood depends on them playing, and that's a different situation to me. But that's how I do it. Yes. It is correct. So so the question is the balanced error system score. Is it correct to say that you get a point for each error, and therefore the higher your score, the worse your balance? The truth is yes and no. So the balanced error score was developed that way, absolutely, and that's the way I use it in clinic. When they had the last international consensus on concussion in sports, they put together a tool called the Sports Concussion Assessment Tool version 2, the SCAT-2. And in it was the balanced error score system. The problem was they combined the balance and the cognitive tests together. And since your scores on the cognitive tests, each point you get, the better you did, they couldn't have the balance score going the other way because they were adding them all up to get a total SCAT score. In isolation, yes. Yes, so if you're using the balanced error score in isolation, yes, The higher the score, the worse you did. You could not get a 60 though, so the worst one you can get is 10. So once you get to 10, you stop the test. So if before 20 seconds is up, they scored a 10, you just stop it and you go on to the next one. So the highest you could get is 30. The reason it's confusing and you're getting these articles to review is that if you pull the best out of the SCAT-2, you start with 30 and then they deduct one every time you get an error, so it's completely confusing. But in isolation, you're absolutely right. That's the way you do it. Yes? Great question. Yeah, so on computerized neurocognitive testing, how important is it in the environment? It's everything. It's absolutely everything. So now, people want to sell stuff and everybody wants, you log on at home. Some kids are logging on at home. Yeah. Yeah, brutal. Can't do it that way. It's worthless. It really is. Because, kids at home are listening to radio, they're texting their girlfriend, they're doing this, the mother's calling them for dinner. It's not feasible. Yeah, and no one checks for validity, it's sort of a hassle. So it's got to be the same situation. And further, the same time of day, there's this new trend now where if you're symptom-free with cognitive rest and with cognitive exertion and physical exertion, they will test your impact or whatever you use for a computerized neurocognitive test. And if you're back to baseline, they exert you, and then when you're done exerting you, they test you again. Okay? I'm completely against that, unless that's how you got your baseline. Tracy Covison, athletic trainer out of Michigan State, took totally healthy people, baselined them, worked them out, tested them again, and they did worse. Of course, now they're exhausted and tired and they can't concentrate because they're ready to fall asleep. And so you have to have your post-injury test the way you had your baseline, or it's not useful. Yes? The computerized neurocognitive test? We do, and actually, you're right that maybe they don't, and certainly the younger you get, it's hard, or the test is not valid until the age of 11, and certainly the older kids, I hope, can fill that in. But that does not factor into their scores, not their cognitive scores. And so even if you could get that information with the parent during the history, but it won't affect their cognitive scores. The other thing is I worry a little bit. If you have a mother fill out the post-concussion symptom scale and an athlete fill it out and then the father fill it out, you get three totally different. Yeah, the mother thinks the kid's on the verge of death, the dad thinks the kid's making it up, and the kid's kind of somewhere in the middle. So I always value the athletes more importantly. Not that I don't value the parents, I do, but I always try to get the kid to give me an honest assessment of what's going on. And I really look to the parents more, do you believe this? Because parents know their kids better than anybody. Yeah. Yes, sir. Yes. Yes. Yeah. 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 Great question. So the question is rolls for neck, a roll, R-O-L-E, for neck rolls, R-O-L-L, or cowboy collars. So for those of you who don't know about this, if you remember Mark Proctor's talk, he was talking about burners and stingers, right? You call it lateral bending at the neck, and you either pinch the nerves as they exit the neck, or you stretch the brachial plexus, and you get burning or paresthesias down the arm. Neck rolls or cowboy collars are used in football to prevent that lateral bending in guys who've had repetitive burners and stingers. We do it all the time. And so the question is there, if concussion is due to a rapid rotation of the brain, is there a role for that? Could they potentially prevent it? There is a guy who's doing this like shoulder pad helmet fusion where it's all together. I worry a little bit about the biomechanics and what that's going to do. I think the cowboy collars, neck rolls, it might help if you got a blow right under the chin. Of course, if you get one on the face mask, it'll help the lateral bending, but not the rotation in this plane. So it might be helpful, but I would say not so much so that I would institute it league-wide. Yeah. Yes? Yeah. Great question. So the question was, do you find neurocognitive testing done outside your office, at a school or at a center or something like that, useful? I do, absolutely. I ask the athletes often, what was the circumstances when you took the test? Some of them will tell you frankly, I don't know, there was nobody in there, there was 20 of us joking around, my buddy kept throwing paper, spitballs at me, you know, it's like, then I know, I mean, that's not. Others will say, nope, we had 2 coaches and athletic trainer there, it was totally quiet, we all had to focus, when we finished, we had to put our head on the desk till everyone else was done. To me, that's more useful data. I will check all of them for validity. I don't assume that they were valid to begin with. And if the scores are comparable, fine. You know, the neurocognitive data, I don't want to overemphasize it. To me, of all the things we do, it's less important. To me, it's more important that you're symptom-free, that you've caught up in your schoolwork and you remain symptom-free with cognitive exertion, that you remain symptom-free with physical exertion. Still, I consider it valuable. And one piece of the puzzle, if there's something not gelling, the scores are way different, even though the athlete reports maybe he's doing 1,000,000 times better, maybe 1,000,000 times better. I ask about the circumstances, both about the baseline test and the current test. I say this joking around, but the truth is, guys who just broke up with their girlfriends or who are worried about getting, they're waitlisted at the only college they have left to hear from, all that, it's going to affect your scores. And so you got to put them in the proper context. Great. Well, I think all the speakers will stay after if you have one-on-one questions. Thanks so much, guys.